so I can go as long as I want. So we're good. This is another meta lecture, and it's pretty much as meta as you can get. I'm going to talk about critical thinking in the emergency department, and we talk a lot about, the actual job that we do in terms of, how to deal with patients, how to take care of patients with drowning, how to all those different things. But we don't talk a lot about what our brain is doing when we do that. Okay, and that's kind of the point of this talk. And this is a complex topic. I'm not going to declare myself an expert on it. I don't think anybody's a really true expert on the human brain. And the point of this is really to kind of introduce you to some concepts in terms of how our brain works, what are some of the pitfalls of how our brain works, and maybe a little bit on how to mitigate some of those pitfalls if possible. All right, so what is the job of an emergency medicine physician? So according to the US Bureau of Labor and Statistics, it's this. We make immediate medical decisions and act to prevent death or further disability, provide immediate recognition, evaluation, care, stabilization, and disposition of patients. May direct emergency medical staff in an emergency department. I think it's actually a pretty decent description of our job. But if you had to think of a few words to describe what emergency medicine physicians do in terms of what our job is, what words would you throw out? Like the core of what our job is. Triage. What else? I heard stabilize. What else? Triage, customer service, that's part of it. But I don't know if that's the core of what we do. It's how we do our job well. But I don't know if it's the core of what we do as EM physicians. Talk to people and poke them. Okay. Also a part of how we do a job, but I don't know if it's the core. Okay, that's part of our job here, but not necessarily all emergency medicine physicians. We resuscitate, right? We stabilize, we resuscitate, we treat, right? And sometimes that treatment is through compassion and empathy, right? And we disposition. That's kind of like the course of our job. And a lot of this depends on our job to diagnose. Sometimes the stabilization resuscitate is less involved in the diagnosis, but to do that job really well, at some point, you're gonna have to think about what's actually going on with the patient. In order to make treatment decisions, you have to diagnose. In order to make a disposition decision, you have to have some idea of a diagnosis. Does that mean we always come to the right conclusion at the end, or always have to? No, because sometimes it's about stabilization and understanding where the patient needs to go next without the complete answer, because we don't always have the complete answer, right? So I'm not going to talk about how to stabilize patients or resuscitate patients or to treat patients or which patients to disposition home or disposition to the ED or to the floor, to the ICU. I'm really going to focus on how we think about diagnosing and how we come to diagnoses, right? And diagnostic errors in particular, because they happen, right? We all know that we make mistakes in diagnosis. How do we know that? Well, we've all done them. One, right? We've all had personal experience with it. But how is it studied? Does anybody study diagnostic errors? It's a really hard thing to study. How it's really hard to study the errors that we make in our diagnoses. So where does we get this data from? So you'll see a lot of data from litigation, right? And so I'm not one who likes to practice to avoid litigation. I think we're all going to get sued. And I think my goal of practice is to provide quality care. And I think that they're aligned most of the time. Quality care, avoiding litigation, you can usually align those. It's not always 100%, right? But you don't want to get sued. And so if you look at the litigation data in emergency medicine, more than 50% of cases involve some sort of failure of diagnosis, okay? Does anybody know what the most common diagnosis in emergency medicine litigation are? Anyone? Stroke is not that high up. It's up there, but does anybody want to know number one? It hasn't changed in years. It's MI. MI is the number one thing. It's on every list. It's been there for decades. Other ones high up on the list are dissection and appendicitis. And I think there's other things there. There is like orthopedic stuff is on there. I think there's a lot of like hand injury, but the big ones are really MI, dissection, appendicitis. And if you think of those are kind of hard to diagnose. And we'll talk a little bit about our thought process in diagnosis. This is not a lecture on how to avoid getting sued. That's a separate lecture, but that's not what this is. All right. The other place we get data on our misdiagnosis is autopsy data. A lot of this data is flawed. The litigation data is flawed. Our autopsy data is flawed. The number that's most often quoted from that autopsy data is somewhere in the 10 to 20% range. That we miss the diagnosis, or we say it's one diagnosis, but the autopsy shows something completely different 10 to 20% of the time. That's actually a lot, right? So what is a diagnostic error? So it's classified into three things, right? There's delayed diagnosis. So that's where it takes longer than it should to make the diagnosis, which may or may not impact patient care, right? A lot of times misdiagnosis doesn't actually impact what happens to the patient. Not every misdiagnosis is going to end in a death, right? There's wrong diagnosis. You make one diagnosis and it's really something else, or just a misdiagnosis where you didn't really diagnose anything and there really was something going on, right? And these are kind of like the classifications of diagnostic errors. And the whole point is you want to avoid diagnostic errors, and that's kind of one of the points of this talk. Now, if you want to say what are the major causes of diagnostic errors in terms of like broad strokes, you can say ignorance, or sort of lack of knowledge, or some sort of cognitive error, right? And I think the truth is that ignorance or lack of knowledge is not often going to lead to misdiagnosis. Yes, your residents, some of you have yet to work a shift as a resident, but you have a lot of knowledge. And the whole point of residency is to gain a lot of knowledge, right? And what did I say the top three things in litigation were? You all know what an MI is. You all know a lot about MIs. You all know a lot about dissection. You know a lot about appendicitis. So you're not missing the diagnosis of an MI because you're like, what's a heart attack? I've never heard of that, right? Like, you know what that is, right? So you're not missing it because of ignorance. So the chances of missing a diagnosis because you've never heard of it is extremely rare, right? Most of the times you're going to miss the diagnosis because you made some sort of cognitive error. So let's focus on that. Well, first we have to focus on how our brain makes decisions as a whole. All right. And some of you might be aware of some of these concepts. Some of you might not be. So this is where I'm going to talk about the dual process theory. Who's here has heard of the dual process theory? Yeah, most of you, right? So I'm going to talk briefly about this. And this is something that has been talked about in the realm of psychology since the 1800s, probably even earlier, honestly. In terms of the system one, system two, that's really Daniel Kahneman, who wrote Thinking Fast and Slow. But a lot of his work is based off of work of psychologists before him, stuff that was described in the 70s and 80s. But he described system one and system two, right? And the idea is that when our brain functions, we're either using our system one, which is kind of like the intuitive heuristic, like we have a set of patterns that we do and our brain automatically does it. It's unconscious. Our brain is doing it unconscious. You're not thinking through the steps of your shower, right? You're just going to shower and you do what you always do, right? Unless there's a special situation, right? This is experience driven, right? Maybe the first time you've ever taken a shower as a kid, you have to think the process through. But now you've done it a lot of times. You know exactly what order you do everything. You probably do the same most of the time, right? It's fast, but it's vulnerable to error, right? System two is much more analytic, right? But you don't want to sit and analyze everything you're doing when you go take a shower, right? You're not going to be like, okay, I got to do this soap and I got to do this part. That takes too long. It's too much cognitive energy. But when you're up against more challenging concepts, that's when your system two gets engaged, right? It's more front in our mind. Our brain is analytically going through all the different it's slower and it involves a lot more of our resources, right? So let's talk a little more about system one, because most of what we do is going to be system one, even in the emergency department. A lot of what we do is going to be system one. Your system one, and that's because our brain defaults to system one. Daniel Kahneman talks a lot about our lazy brain. Our brain is going to default to system one anytime then it can. right? So, and a lot of times that's great, right? When you're showering, the patient who comes in, who's like 30 years old, who comes in, she just got off a plane for 12 hours, had surgery on her knee a week ago, and comes in tachycardic with chest pain and shortness of breath. Your system one is going to engage really fast there, and you're going to say, okay, this patient probably has a PE, right? And you don't want to waste cognitive time necessarily on that patient who's really straightforward. You're not going to need to engage your system two on a patient who has a fracture necessarily, right? But there are risks associated with it. When you go fast, there's more chances for errors to be made. That's not to say that system two doesn't have its own downsides. Okay. And even if you want to use system one as much as possible, you just can't, right? So that patient who just got off the plane, that's a straightforward case. But what if, let's say it's a 30-year-old woman and now she has SLE and she's on immune modulators and she comes in with chest pain, abdominal pain, and fever, right? You're not going to system one that, right? You're not going to be like, oh, it's, pneumonia or something else. That's a much more complex patient. You're going to have to sit and actually use your brain, analyze, do some more tests, try to figure out what to do. All right. So how do we make mistakes? What are the errors that happen? Why do we make these errors? And it's a complex question, right? I think what most people talk about biases or cognitive errors. And that's what I'm going to talk about a little bit for the next few minutes. So biases, cognitive errors, cognitive dispositions to respond. So I mentioned Daniel Kahneman. He kind of discussed this in terms of behavioral psychology and behavioral economics. But Pat Crosscarry is a physician who's probably done the most writing on this topic in medicine. He's actually an emergency medicine physician in Canada. We'll forgive him for his Canadianness. And he writes a lot about this. And he likes to call these cognitive biases or diagnostic errors or cognitive errors CDRs because it's a lot less negative sounding, right? Because when we talk about our biases, it sounds like we're making a mistake. And while we are making a mistake, we're not actually doing anything wrong because it's our brain that's unconsciously going about what it's supposed to do. It's functioning the way it's supposed to. And it's making the error not consciously, but unconsciously. So it sounds like, oh, when you say like, oh, that person was anchoring on something, it sounds like they were doing something bad on purpose. But they're not. It's their brain that's making this decision without them even realizing it, right? And so these are some of the common kind of diagnostic or errors that we can make in terms of our biases, right? So you've all heard of these terms, right? Things like anchoring, where you basically come to a diagnosis pretty early on, and even if you get other information, you kind of ignore that other information in order and don't want to adjust your diagnosis based on new information, right? And that's kind of similar to diagnostic momentum, where once a diagnosis is made, it continues on through despite whatever workup is getting done. There's confirmation bias, where you only look for the data that's going to confirm your diagnosis and might ignore other data. These are all kind of in the line with the same thing, but kind of subtle differences, right? There's premature closure. Also kind of similar, and you basically you accept that diagnosis before even doing the full workup. And then there's like things like search satisficing. Once you find the diagnosis and you find it, you might be right, but you like kind of don't look for anything else. And that's like, what's the most commonly missed fracture? And that's the second one, right? So you find one fracture, but you don't look for the second fracture, or the or the patient with like the co-ingestion. I always think about the patient I had a long time ago who came in, he stabbed himself multiple times in the abdomen. And we did this whole trauma workup on him, and he was still kind of sick. And it took us a long time to figure out that in addition to stabbing himself in the abdomen, he also ingested ethylene glycol, right? And that's like, it was the obvious, oh, he stabbed himself. So, we were doing this whole trauma workup and evaluation, but really he just had ethylene glycol toxicity, and his stabbings were actually mostly superficial. But it's not just those things, right? Our frame of mind has a big impact on the decisions we make and the chances of us making cognitive errors. Where we're at, right? When you walk into your shift, did you sleep 2 hours last night, or did you sleep 8 hours last night? And if you slept 2 hours, the chances of your system one failing and entering into some sort of error or making a diagnostic mistake increases, right? How are you feeling? Are you burnt out? What color are you on that wellness scale, right? How many nights have you worked, right? And they estimate that, I was talking about this the other night as I was reading about this stuff, is that at 4 or 5 in the morning or 3 or 4 in the morning, you're like intoxicated, essentially. Now, obviously, we can't avoid working at night. You can't just be like, oh, we just won't work at night anymore. We're close down the ED because, but that's just the reality where we're at, right? Did you have an argument with your partner that day or the night before, and you're kind of stressed out, or whatever challenges that you're having in your personal life? Don't think you can just leave all that at the door as soon as you walk into the emergency department. It impacts how your brain functions and how you work and how your system 1 works and even how your system 2 works in terms of where you're going to get and what diagnostic errors. And just to follow up with the last lecture, how do you feel about the patient in front of you? Do you hate them? Because sometimes you will. Do you love them? Do you love them? Sometimes you will, right? Talk about little old ladies. My favorite little old lady of this year was, I went to go talk to her and I said, oh, what's bothering you? And she said, you are. So, and I was like, I love you right now. That's you had me, right? And the patient that you hate, you might want to just say, this is not anything, this is not a big deal, and you might miss the important diagnosis. And the patient that you love, you might say, they can't have the bad diagnosis because I don't want them to have the bad diagnosis, so I'll give them the less bad diagnosis, right? And your brain is doing that without you even knowing it, right? And it's not just your mind, right? But it's your environment. I don't know if you guys know this, but the emergency department is kind of chaotic, right? And I don't know, I think Pat Proskauer was quoting somebody, but he said like the emergency room is a natural laboratory for error, right? Because it creates an environment. Like, how often do you get interrupted when you're in the emergency department, right? Like I'm all sitting there, I'm thinking through a patient, and then next thing I know, I got 4 EKGs sitting in front of me, right? And that's kind of just part of our job, is we're going to get interrupted. There's a lot of task switching, right? Because you're taking care of multiple patients. A lot of times when we analyze patients, like an M&M, we think about the one patient, right? We don't talk about what the room is like. We don't talk about the fact that you were taking care of 6 other patients. Even if the room isn't busy, you're still concentrating on 17 different things. And when you take it in a silo, everything was very clear, but you're not working in a silo with one patient when you're in the emergency department, right? And your environment has a huge impact on how your brain functions and how it makes decisions, right? And there's also the framing biases, right? So the same exact patient you can see in CCT, in Fast Track, in the main ED, and in all 3 of those places, you might do something completely different, right? If you have a patient with a headache and they end up in Fast Track, you're gonna be like, here's some Tylenol, Motrin, you're gonna go home. But in CCT, you might be like, oh, they had this, and the EMS brought them in. Maybe we'll do some CAT scans, and maybe we'll get neurology on board. And in the main ED, you might be like, all right, we're gonna do this. We'll think about doing a CAT scan, right? But depending on where you are, right, that might impact how you take care of the exact same patient, right, and where they came in. Here's some other like kind of biases that like we see often. Availability bias. This is usually something that sticks out in your mind, right? And that's usually from a bad case. You had a really bad PE case the week before, and so now every single patient with chest pain, you're going to be like, does this patient have PE, right? And it's, you can't avoid that, right? Or it's in the middle of flu season, so like you're seeing 35 flu patients a day, and so the patient who comes in with fever and chest pain, it's just the flu, but they might have pneumonia or some other significant infection, but everybody else has the flu, so therefore this person has the flu, right? Triage queuing. How often do we see patients who get triaged as intox and their E2H levels are negative and there's something else going on with them, right? But that bias, that's kind of like the diagnostic momentum, but that bias that you get from the nurse coming up to us like, oh, it's this patient, they're here all the time, this is what they're here for, they just want a note or something to go back to the shelter. And then that's how you walk into the room thinking you're not going to be able to like avoid some of the missteps of the diagnostic errors. The psych out error, right? That's for psych patients. That's a whole classification of your affective bias. The psych patients are really hard to deal with, but they get sick like everybody else. And we walk into the room and you're just like, oh, I just want to, get this patient to CPAP. but there might be something wrong with them, and it's really hard to do it, right? Playing the odds or frequency gambling, that's where like you're not really sure what's going on, but you're like, most of the time, this is not anything serious, so it must be that less serious diagnosis. You have no data to support that, but you're just playing the odds on that. Now, that's not necessarily bad. You can't do an aggressive workup on every single patient that's unambiguous, but these are places where diagnostic errors happen, right? The zebra retreat, right? Like, you don't want to be the one who works up all the zebras, right? You don't want to be like, oh, that patient has neck pain, we should do a CTA to rule out vertebral artery dissection, right? Because you don't want to be that person. But maybe that patient does have vertebral artery dissection, and if you don't work up some patients for the zebras, you'll never find them when they actually happen, because rare diagnoses still happen, right? And then my favorite, just because of the name, is the yin yang out, right? So this is the patient that's been worked up the yin yang, and like you're like, well, it can't be anything bad because they've had all the workups already. They've already had 4 CAT scans in the last month, and they've had all these lab tests. So therefore, and they've been to 7 doctors. Therefore, there must not be anything wrong with them, right? And so that's called the yin yang out bias. And look, there's a lot of biases. There's hundreds of them. And we can sit here and talk all day about the various biases. I think the most important thing to understand is that they exist and the list is long. And every single one of us is susceptible to them. So now that we know that we are going to mess up and our brain is defective, all of our brains are defective to a certain extent, can we fix them? Is there a fix? There isn't an easy one. Daniel Kahneman, who I mentioned, he doesn't really think we can debias. He died in March. So, but he didn't think that you can really debias, right? And so, but I think that you have to try, right? And so, what are some of the steps that we could take as individuals? There's a lot of different things that you can try to do to avoid diagnostic errors. Some of them are on a system level, right? But what can we do on the personal level, right? So I think step 1 is this, right? It's knowing that this exists, knowing how your brain functions, knowing where those pitfalls are, understanding diagnostic errors and understanding the biases that lead to them is the great first step in trying to avoid it, right? Because if you don't know it, you can't diagnose it, right? And that works for your brain as well. Right. So I think the best first step is to understand this. And obviously, this lecture alone is not going to be the solution to all of these problems. Right. And you have to continue learning about this and continue thinking about it. Right. And that leads us to the next thing. Right. And that's metacognition, or thinking about thinking. Right. And it hurts the brain a little bit because it's kind of like circular. Right. But if you think about how you're thinking, right, and thinking about what your thought processes are, you're much more likely to find maybe something that's going on, or understand what you're doing, and maybe you're less likely to make a mistake, or when you do make a mistake, to be able to adjust, right? Because your system 1 very much functions on experience, right? My system 1 is a lot better than yours. Sorry, not better than Dr. G's, right? But it is just because I have experience and adjust with time, right? Ideally, when I make a mistake, I go back and I adjust my system 1 so that mistake doesn't happen again. It will, right? My system 1 is just as prone to mistakes as yours. It's just it's a little bit better. Okay, so understanding how you're and thinking about how you're thinking is hopefully a way that you can kind of mitigate some of those biases, right? And as I like to say, engage your system 2. Now, a patient has a laceration to their finger, you don't really need to think much about that person, right? But you have to sometimes force yourself, even if it's the 30-year-old with chest pain, right? Sometimes you have to force yourself and say, look, I know this is probably musculoskeletal pain, but let me take a step back and think, let me engage my system 2 for a minute and say, let me make sure I'm not missing something. Let me make sure I'm not pushing away information that I want to ignore. Let me just take a look at that ECG. Let me think about this patient, think about the story that they told me, and make sure it all fits in to that musculoskeletal picture. And as I like to say in M&M a lot, don't try to push a square into a round hole, right? And the best way to avoid doing that is to think about what you're doing and force yourself to think through the patients. Not every patient you're going to be able to do it. And in the ED, I don't always remember to think about every single patient because system 2 involves a lot of cognitive load. And we just frankly don't have the cognitive energy to engage system 2 on every single patient we see. And those are kind of 3 things that you can do to kind of help mitigate. There's a slew of different things that we can do, but those are just some of the things that you can do in order to move forward to help avoid the diagnostic errors. Do these work? The data on whether or not this actually works is actually unclear, but I think we always have to try to be better, and that's kind of our job, right? Does anybody have any thoughts, questions, comments from faculty?
Yeah, when you're talking about the thinking about thinking, things that you have to do, but on shift, sometimes I have that patience where I'm like, do I think this patient needs the pelvic exam, right? And you're like, I don't think so. And then I think to myself, well, this patient wasn't in the hallway, fully clothed. What if this patient is actually in a private room, in a gown, with a chaperone that's just sitting right there like a chaperone? Would I in that case say, well, it's really easy to do this. I think it's important, so let me do it. Or am I saying, I don't think they're really needed because they seem okay, but also I know I have to find a room, find a gown, find a chaperone. And sometimes that's how I'm thinking about how I'm thinking. Like I try to prove to myself, if this was an ideal setting, would I do it differently? Now, just because it's not the ideal setting doesn't mean you should still do everything, right? You still have to utilize our resources. You can't just MRI everybody because the MRI is available, and that was the case. But that's just how I think about some of my workup plans and try to keep myself honest. I try to remember to keep myself honest. I can't do it for every patient either.
And that brings up another important pitfall of system 2. It could sometimes mean too much, right? Like sometimes you really don't need system 2. And if you engage system 2, you start doing a whole workup and you start going down a whole route that the patient doesn't really need, right? So there's pitfalls to both, but certainly just being aware of it is really important.
Something when I think about this a lot, I think Dr. Schechter and actually hasn't talked about Rich kind of touched on this concept is reflection as well. And a lot of times I think, especially when you're a young or newer physician, it's hard to reflect on your mistakes. It's shameful, you feel guilty, you don't want to think about it, like, all right, that's done, I want to do it. But really just look inward and see what you brought to that situation. One of our speakers at graduation, I think, did a good job talking about it too. A good time to engage system 2 is when a consultant or a admitting physician is telling you something different. And Dr. Ferrari, she said, ask questions, be curious, take a second. It's everyone's natural first instinct to be defensive and be like, no, you're wrong. And sometimes they are wrong, sometimes you're right. But take a second, think. Is there something I'm missing here, or something that they know something more about it, or they're bringing something in that maybe I missed?
And I think, I hope based on that, I hope something you take away from this is realizing that when we make the mistakes, it's our brain doing it and our human brain doing it. And very rarely is it on purpose. And that's the point. Like I said, the lack of knowledge, that purposeful, it's an unusual cause of our diagnostic errors.
Yeah, I like when you said take the next step, but the other important thing sometimes is take a step back before you make final decision. Just give it another thought. Especially that helps you avoid sometimes anchoring. But say to yourself, is this all making sense? And if it's not, then maybe you have to take another route, or at least consider another route. The other thing is we're all going to make mistakes, especially at the beginning. And an important thing is to learn from your mistakes. I missed my first dissection. I missed the subarachnoid. And it's not that I'm going to every single one. I'm going to CTA every single chest pain. But you learn about what things should set off that trigger. Then maybe I have to take another step.
This talk on my PhD things that I found really important that I realized by the end of residency is that one, patients might not present with the signs and symptoms of the disease. It might be the signs and symptoms of a complication of the disease. So if you feel like, so that's one part of it. And the other part is when I always sit down, I ask myself, is the math mapping? And then I've done this full workup and the math is not matching, there's one thing that does not add up to the 100 other times that I've seen this thing. I go back to the bedside and I start my history and exam all over again, right? And when I do that, I feel like I miss a lot.
And then I like to tap into other people's system too. I think it's a nice thing that we have this department, and so like I've been on shift, like mine is not as developed right as Schechter or Dr. G, but I've been on shift with Dr. G and like looked at a movie and then got Dr. G as an attending, I'm an attending now. And been like, Dr. G, can you look at this with me? Like, what do you think about this? And then he'll come in with a lot more experience and then sort of add to watching him think about it helps add to my system.
Any other thoughts, questions? So just remember, you're gonna make mistakes and that's okay, right? It's important to understand why you made the mistakes and go back and analyze them. Understand how your brain works in terms of the dual process theory, and get that these biases exist, and by knowing the biases, there might be a chance that you're less likely to fall into them and avoid them to a certain extent. Here are some of the resources that I used. This is the Thinking Fast and Slow by Daniel Kahneman. It's a great book to read about these concepts, not necessarily applying to medicine. That QR code is to a YouTube video by Pat Crosscarry talking about these concepts, if you guys are interested. And that's it.